For week 7, we have a couple different topics, so I made 2 different PowerPoint and lectures. The first one is women's health. There are a few health conditions that fall under our women's health category. So we have pregnancy, lactation or nursing, birth control, and hormone replacement therapy. So those are all seen on the back side of the medical history form, and on this page to the right, there's that women only section. So men, that is the only area on the medical history form that men actually are allowed to leave blank because it doesn't apply to them. So, and then we're also going to group osteoporosis into this lecture. Osteoporosis is not necessarily only a women's health issue. It can also occur in men, but it's definitely more prevalent in women. So that's why we're going to bulk it into this lecture, and you can see on the left side of the form, there's a couple questions, and they are about if the patient has ever taken medications to treat osteoporosis and what kinds of medications that they're taking. We'll talk about later how those medications can affect the oral cavity. When a patient is pregnant, there are some considerations that we'll make as oral health professionals. The first is that we are going to do any kind of elective dental treatment in the second trimester of pregnancy. So when I say elective dental treatment, what I mean is something that's routine, like a cleaning, some kind of treatment that is aesthetic in nature. We want to do that in the second trimester because it's considered the safest. So having in the first trimester, the fetus is developing, it's forming, there's a lot of organ formation during this time. It's a crucial time for the fetus developing. So we don't technically do any kind of elective treatment then. And then in the third trimester, it gets a little bit more uncomfortable for the patient sitting in that supine position when the belly is bigger and there's a lot more pressure. We tend to like the second trimester. Now, if there is an emergency, the patient's in pain, if they need to have a deep cleaning because they need to get their mouth healthier, because there is a correlation between the mouth being unhealthy and preterm low-weight babies, and you'll hear that a lot through this program. We don't have to only treat in the second trimester, but we just consider that the safest. So if there's any elective treatment that doesn't need to be done right away, that's when we're going to do it, is the second trimester. Also, another thing to note about appointments for pregnant women is that usually the best time for their appointments is in the afternoon. So sometimes, and if you've ever been pregnant before, they talk about morning sickness, and from what I've heard, sometimes if you have morning sickness, it's not really morning, it's all day long. But if someone is having morning sickness, it might be better for them to have an appointment in the afternoon so that they can not have as extreme sickness and being as sensitive during their appointment, especially with some pressing on the tongue, which we all do, and stimulating any kind of gag reflexes. So afternoon appointments are best for pregnant women. Pregnancy is not a contraindication for radiographs. That's kind of a myth that was put into people's heads a long time ago, that you could never get an x-ray when you were pregnant. Using our proper radiograph techniques that we use, that you guys are all learning about, meaning using that lead apron to protect the patient, the collimated tube head that directs the x-ray radiation in that one particular area, the lead foil in the backside of the film to stop the scatter radiation, or if you're using a digital x-ray, you have a much faster exposure time and there's much less radiation that occurs with digital. I think our book quotes about 90% less radiation with digital x-rays. The likelihood of having a fetal exposure is really low. So when we're doing all of these techniques to minimize the amount of radiation, and to actually think that you're going to have a fetal exposure for one radiograph is extremely unlikely. That being said, we're not going to be taking x-rays just for routine purposes. So sometimes the ADA, we go by the ADA's recommendation of taking bite wing radiographs once a year or once every year and a half, depending on the patient's risk. If there are no concerns of pain or any clinical concerns, then we don't have to take those routine x-rays. We won't take those routine x-rays just because. However, if there's an emergency concern, such as, a really bad tooth infection, the patient's in pain, something clinically that's really worrisome, we can take an x-ray to check that emergency concern so that we're able to treat it and diagnose it. Again, we just won't be taking routine radiographs for a patient that's not in pain and is just getting a routine prophylaxis and doesn't have any tooth concerns. There are some dental considerations that we'll want to make when we're treating a pregnant woman. There are some hormonal changes that a pregnant woman goes through, and this increase in hormones can cause a lot of changes in their gingiva. They can have an exacerbated effect to plaque and develop gingivitis more readily, and their gingiva can bleed a lot more readily. They can also develop what's called a pyogenic granuloma. A lot of people refer to this as a pregnancy tumor. It's basically a benign red gingival growth on the gingiva. It can also occur on the skin, and it's not necessarily a concern, but it can be painful for these women. We also want to make sure we're monitoring the blood pressure of a pregnant woman. At RCBC, we're always going to be taking blood pressure, but when you get out into private practice, it will be your choice if you wanted to take blood pressure or not. But for these women, we want to make sure we're on the lookout for any kind of abnormal blood pressure readings. Pregnancy can induce some hypertension and could potentially lead to preeclampsia. So if we do see abnormal blood pressure readings, we want to make sure that we are informing the patient and making the referral to a physician if we see fit. Pregnant women can also develop a functional heart murmur, and this is something that we're not too concerned about. It's not going to require any kind of antibiotic prophylaxis. Heart murmurs do not fall in that category as needing pre-medication anymore. So we're not going to be too concerned about that, but if that's something that a patient, you might expect a patient to report that to you if they are pregnant. And finally, we're going to be careful about what kind of drugs that we prescribe. There are drugs out there that are capable of teratogenicity, which is the ability to cause birth defects. So we want to make sure that we're checking what category of drug that we're prescribing and making sure that it's not going to have any effects on the fetus. Finally, we might make some patient considerations when we are treating a pregnant person. Again, short afternoon appointments are going to be best. The shorter they can be, the more comfortable the patient's going to be, and in the afternoon, the better due to the potential for morning sickness. We want to try to avoid that stimulation of gag reflex. If the patient has any aversions to any kind of flavors, we want to make aware of that so that we're not giving them something that they might be really sensitive to. And also, we want to try to treat these patients in the semi-supine position, especially if they're getting towards the end of their pregnancy, due to the potential of causing supine hypotensive pregnancy syndrome, which is one of the emergency concerns that we may run into with a pregnant patient. The FDA has come up with categories of prescribing drugs for a pregnant person, and these are all based on the teratogenicity, or the ability to cause birth defects in a fetus. So we have categories A and B, and both category A and B you can use for during pregnancy, and they can be prescribed. The difference between A and B is that A has not had any kind of risks in studies to a fetus, and they've done human studies on that. And B, they haven't found any risk in animal reproduction studies. So there's not any human studies available, but we've determined from animal reproduction that they are safe to use for a pregnant person. In category C, you're gonna look at the risks of the risk to the fetus, and then the benefits to the human or the mother. So these are the ones that are kind of iffy, and we're not necessarily sure if they're going to cause birth defects, but they're more on that if the benefits are really going to outweigh the risks, then we consider those. We probably won't be prescribing them as dental professionals, but this would be something that would potentially a doctor would be prescribing. And then we have category D drugs that have definite human fetal risks. So this is only going to be given to a mother if the mother is in a life-threatening condition. So the mother is literally going to die if they don't receive this kind of drug. And then category X are definitely going to cause fetal abnormalities, and they wouldn't be able to be used anytime during the pregnancy. Here are some pictures of the pyogenic granuloma, also known as the pregnancy tumor. They are located usually in the interproximal papilla area of the mouth, if it's on the gingiva, and it usually presents as a swelling of the interproximal papilla that's extremely red. There's a lot of blood vessels to this, so any kind of small disruption to it will cause bleeding very readily. And they can also be seen on the skin. So they can be seen on the fingers, on the back, on the legs, really anywhere on the skin as well. We're going to be more concerned about them when they're in the mouth. So they can be painful. What we usually do is ask the patient if, as long as it's not too painful, and you can see that the right side picture on the top might be a little bit more painful and irritating to the person versus the picture on the left. But what we ask the patient is if they can wait till they give birth, and it might resolve on its own. If we want to surgically remove it, they can do so by numbing the area and excising it either with a curette, depending on how large it is, or a laser to cauterize the tissue around it. But the chances of it growing back during the pregnancy are great. So definitely, if you're going to be treating it, we'll need to know that there is a high potential for growing back. But these lesions, if they are pyogenic granulomas, are always benign, so we're not concerned about cancer in these cases. The one emergency concern that we're going to talk about with pregnancy is supine hypotensive pregnancy syndrome. This is very similar to how syncope occurs, and it is most common in the third trimester of pregnancy, and this is because the baby is biggest and it's at its heaviest weight at this point. So in supine hypotensive pregnancy syndrome, when the pregnant patient is laid in the supine position, the uterus that is heavy and enlarged compresses on the inferior vena cava. This compression on that large vein is going to result in reduced blood flow to the heart. It's also going to slow the heart rate down as a result. So there's not enough blood flow. The body's starting to slow down to accommodate for the reduction of blood flow. And then the body's also going to respond by vasodilating. It wants to get more blood. But in that process of vasodilation, we get hypotension. And when this patient is seated to that upright position due to the decrease of blood pressure, we can have syncope occur. For an emergency, we always have a prevention strategy and a management strategy. So for supine hypotensive pregnancy syndrome, to prevent this from occurring, we are going to seat the patient in a semi-supine position. For a pregnant woman, this is going to be more comfortable. There's not going to be as much compression of the uterus on the inferior vena cava, which is what we're trying to prevent from happening. If the patient is starting to show signs of syncope, we're going to try to manage the situation. So, to do so, we're going to adjust the patient's body to the left by lifting their right leg. So we want to get the pressure off of the inferior vena cava that's running down the right side of the body. So again, you're going to be adjusting the patient's body to the left by lifting their right leg. And you can do so by putting a pillow under the right leg, and that will take the compression off of the right side of the body, which is where the inferior vena cava is running. So we want to take the pressure off the inferior vena cava by lifting the body to the left. It's important for us to know if our patient is nursing after their pregnancy, because we're going to see a lot of the same hormonal changes that we'll see in pregnant women. So we're still going to see potentially increases of gingivitis and exacerbated reaction to plaque, and their gingival tissues might take longer to return to normal. So if they had a pyogenic granuloma, a pregnancy tumor, and they're still nursing, we might have a longer time for that pyogenic granuloma to take to go away. So in these persons, we're going to make sure that we're stressing home care to them, because any kind of plaque sitting on the gingiva they'll still have that exacerbated response to. We also want to follow the same recommendations for prescription drugs, those categories, as we would during pregnancy. So that's still happening. We don't want the mother to transfer any kind of drugs into the baby, so that also correlates with those FDA categories of drugs. For patients that are taking birth control or hormone replacement therapy, both of these drugs are going to have side effects that are relevant to our dental care. Again, they're going to have gingival tissues that are similar to pregnancy, and that's due to the increased amount of hormones. Patients that are taking hormone replacement therapy are people that are either going through menopause, or they're people who need more estrogen. And for these patients, we're just going to make sure that we are stressing home care for them, because they're going to have that exacerbated effect to any kind of plaque. Also, it's important to note that for someone that's prescribing antibiotics, the dentist, you should be advising that patient of the reduced effectiveness of their birth control. So birth control and antibiotics do not mix, and antibiotics will decrease the effectiveness of birth control. So we want to advise them that during their week or however long they're taking their antibiotics, that the birth control will not work, and 1 week after the completion of the antibiotics, they have to give that time for the birth control to be able to work again. If not, that's how oopsies happen. Finally, our last women's health concern is osteoporosis. So this is more common in women, and it is a loss of calcium in the bones. And this can include our alveolar process of the mandible, or our jaw. So there are a few risk factors that people are more increased chances of getting osteoporosis. This is Caucasian and Asian ethnicities, also someone with a slender build, people that go into early menopause, and also people of sedentary lifestyle that aren't really using their muscles and bones regularly. Bisphosphonates are a type of drug that is used to prevent the loss of bone mass. And this is used to treat osteoporosis and also used to treat Paget's disease. It can be given orally as a pill form or intravenously. IV bisphosphonates are going to be more potent, and their side effects are usually more severe. They are used to treat malignant bone disease and cancer, especially in breast cancer and prostate cancer. But they also can be used to treat osteoporosis by itself. Here are some very popular bisphosphonates. Usually people will give you these by the brand name. So there's Fosamax, Beniva, Actonel, and Reclast. They're also listed as the generic name, but most people will give them to you and know them by their brand name. The mechanism of action of bisphosphonates, or how bisphosphonates work. So after they're taken either orally or by an IV, these bisphosphonates bind to the surface of the bones. They bind to the bone cells known as osteoclasts. So osteo means bone, clasts mean break down. So osteoclasts break down or dissolve the bone. When the bisphosphonates incorporate with the osteoclasts, they stop them from dissolving the bone. So as that result, osteoclast production is down, so the bone loss decreases and the bone density is improved. Unfortunately, bisphosphonates can have a pretty significant adverse side effect that can cause significant dental issues. Osteonecrosis of the jaw is one of the side effects of bisphosphonates, and basically this is inadequate healing, usually after dental treatment in the mouth, and it's due to an adverse reaction of oral or IV bisphosphonates. So it's more common in IV bisphosphonates to get osteonecrosis of the jaw, but it can happen in both. To recognize osteonecrosis, they can be painful or it could be non-painful as well, and it is exposed maxillary or mandibular bone. It's more painful if it's infected, and early signs, clinical signs, are going to be pain, potentially tooth mobility, erythema or redness, swelling or ulceration of the overlying mucosa. So at this point, there may not be any kind of exposed bone, but they're going to have early signs of this swelling or ulceration in their mucosa. The reason why osteonecrosis of the jaw happens is not completely clear. There's been a lot of research on it, and what they've come to know as a reason is that the suppression of bone turnover, or the suppression of that osteoclasts from the bisphosphonate therapy, is probably the reason why people develop this condition. So basically, if there is necrotic bone already present in the mouth due to an oral infection, and that's the reason the patient has to get treatment, that necrotic bone cannot be resorbed by osteoclasts. So we're inhibiting, the bisphosphonates are inhibiting the osteoclast from resorbing the necrotic bone that it should be doing in normal healing. So the necrotic bone that's not resorbed inhibits healing and affects the blood supply to the area. So it's because the normal healing process is disrupted and normal healing is not occurring around that area. There are certain procedures that are associated with osteonecrosis of the jaw. The first, most common procedure is extractions. And after an extraction, the body's ability to heal itself and to cover over the exposed tooth socket is inhibited. Also, severe periodontitis, periodontal surgery, potentially dental implants, root canal surgery, so not necessarily any kind of root canal, but actual surgical root canal procedure called an apicoectomy. And then it also can occur spontaneously. So patients that are edentulous and wearing either a denture or partial denture that's continuously rubbing on the gingiva, for patients that are having a lot of bisphosphonate therapy, they can actually have spontaneous occurrences where the underlying bone becomes exposed and infected. There are certain characteristics that need to be present for a patient to be diagnosed with bisphosphonate-related osteonecrosis of the jaw. So they need to have currently be receiving bisphosphonate therapy or have received it in the past. They need to have presented with that exposed bone or the necrotic bone, and it has to have persisted for more than 8 weeks. A very common area for osteonecrosis is the mylohyoid ridge of the lingual side of the mandible. These people can also have no history of radiation therapy. So if they've had radiation therapy, it could be a potential side effect of that. So if they've not had radiation therapy and they're taking bisphosphonates and that exposed bone has been persisted for more than 8 weeks, then we can consider diagnosing them with bisphosphonate-related osteonecrosis of the jaw. Here are some pictures and radiographs that show some clinical features and radiographic features of osteonecrosis of the jaw. So picture A in the upper left-hand corner shows a cutaneous fistula. So it's a pus-filled lesion, and it's right at the angle of the mandible. This is associated with picture number B, which was taken, it's a panoramic that was taken 4 months after a dental extraction. And it shows, if you can look there at that, in that green circle, you can see where the tooth was removed, and there's a big radiolucency that extends all the way down to the bottom angle of the mandible. So then we have pictures C and D, and this is after the patient has received some type of therapy, potentially no therapy, and it's just slower healing. And this is where the fistula is healed, but there is scar formation there. And then on the right-hand side, the radiograph where we can see bone filling. It's not completely filled yet. You can see it's more still radiolucent at the coronal portion, but at the angle of the mandible at the bottom border, we can see that there is more radiopaque bone fill in that area. And this person has received 5 months of therapy at this point. Unfortunately, I don't know what kind of therapy that they were receiving, but that's what the pictures have shown as 5 months. There are stages of bisphosphonate-related osteonecrosis of the jaw, and this helps surgeons be able to accurately diagnose and know the progression of the disease. So we have stage 1, where we have the exposed bone. There it looks like it's on exactly the place that is most common, which is the lingual of the mandible. And in this area, there's no indication of inflammation around the soft tissue or around the bone. Then we move to stage 2, where we have more inflammation, soft tissue and bone inflammation, and this is more painful for the patient in stage 2. And then we have stage 3, and a big significant difference in stage 3 is a fracture of the bone. There's an extensive amount of exposed bone, and there's a lot of soft tissue inflammation and infection at this point. There's no true way to prevent bisphosphonate-related osteonecrosis of the jaw. Like we talked about, it can occur spontaneously without doing anything. But we can educate our patients and let them know the risks of bisphosphonate therapy. And we can also know that if they are starting bisphosphonate therapy, we want to do any kind of treatment, necessarily surgical treatment, before they start the therapy. So we want to do a thorough oral exam prior to them starting their therapy. Remove at that point, do any kind of extractions of hopeless teeth. So if there's any teeth that are showing signs of infection or have a very poor prognosis or hopeless prognosis, we want to remove those teeth prior to them starting the therapy. Any kind of periodontal issues should be treated and resolved prior to starting therapy, and we're really trying to get their dental health to be as optimal as possible for them prior to their therapy. And we want to make sure their areas of any kind of treatment, extractions and such, are healed prior to starting therapy. If they start on the therapy during the healing process, then we can start to have issues. We want them to have optimal oral hygiene. We don't want them to have the need in the future for extractions if they're on this therapy. And again, educating the patients on the side effects and making sure that the patient knows the potential issues that can happen when they're taking bisphosphonates, especially with IV bisphosphonates. To manage bisphosphonate-related osteonecrosis of the jaw, for someone who's diagnosed with it, the goals are going to be to eliminate pain, control the infection, and try to minimize the progression. Patients may get surgical debridement, so going in and cleaning out the areas of necrotic bone and trying to get the underlying healthy areas to heal, keeping it really clean in the meantime, and potentially prescribing antibiotics. These kinds of cases are going to be referred out to a specialist, either an oral surgeon or someone at a university that has significant experience in treating this condition. So this ends our lecture for women's health and women's related issues. Our next lecture will be on other conditions such as kidneys, eyes, and thyroid dysfunctions for this week.